Okay, great.
You can talk really quietly.
Yeah, it's really loud here. Well, thank you everybody, and thanks Dan for inventing a great machine. So I started off Visian ICL in 2008 when the US approved in 2006, and we did pretty well with the G4 with a little fudge factor about 0.7, and also verifying it with a manual caliper in this gray area. And I always aim for the smallest that I can find. Not, there's a gray area, so you got to find the right place. And we measured the ACD with the G4. We used the manufacturer's nomogram, and we generally had good results, but there were a couple outliers. In 2020, we started using the ARC scan to try to reduce these outliers. And we started learning more about it, but the biggest improvement was really when the EVO ICL came. And in this country, it didn't get approved until 3 years ago, which is very embarrassing. But it was approved in 2011. So with this new lens, there's a significant improvement in the visually significant cataracts, and also all these other risks. So we kind of talked about these studies, but what we learned from the EVO ICL and what STAR tells us and what we've seen is it's definitely a lot safer. There's a lot more acceptable lens sizes that's gonna not cause a problem at this time. And but we know that the vault is gonna decrease, the chambers are gonna get smaller over time. And so the question is, can we determine an optimal available size for each eye, both for now and the future? And let's fit that in the eye. So my experience is to really place the lens into the chamber and have enough room to be away from the crystal lens. But my thinking is really not the vault. I know there's so much focus on the vault right now. I think the more important parameter to look at is really the angle, the post-operative angle. Like, what should it be? And 2 years ago, we were with the high volume EVO ICL surgeons in the world, and we all kind of thought that 15 degrees, arbitrary number, is a safe amount. Really, to close out the angle, you probably have to get down to 5 degrees. You should verify with gonio, but 15 degrees is what I want to aim for. Not ideally, I want to be 20 degrees, but 15 is when I start thinking about needing to remove the lens. For spherical, I try to target between 250 to 750 microns. With the toric, I'll go a little bit higher, up to as far as 1,000. But again, the most important thing is, I want to maximize the angle, the post-operative angle in spherical cases. And we do have a lot of patients that are, very low ACDs that we're concerned about. If they're toric, we want to get at least 500 microns, and is what I aim for. And the angle, of course, we want it to be ideally 20, 25 degrees. So using the ARC scan Insight 100, it's really helped us. A couple other techniques that I use is based on knowing that the sulcus is usually longer vertically, and also the CBID is longer vertically as well. So there's also a paper by Dr. Lee, which talks about where you have less rotation with vertical lens. And he's one of the most experienced in the world, and he's done probably 40,000 EVO ICL surgery. And he has a great paper on that. We've already seen this that Dan showed, and basically this machine is really easy to use. I know there's been some talk about it's very difficult to use. Our technicians do use it every day on every single patient, and we get these beautiful pictures and with all these parameters. So a robot takes these pictures, it's just lined up. ArcScan calls it eye spot, but it's pretty comfortable. Okay, so it's not like an ultrasound where you're kind of pushing into the eye, the handheld. This is very, very comfortable, easy to use. And then we plug it into the Dr. Reinstein's formula. And what I look at these numbers here, and what I do is, if it's very clear which lens size to go for, then we just do it. But if the patient is a toric patient, 25% of the time, I'll actually operate on the second eye the next day. Okay, and that's because they're in between sizes. Also, look at these numbers here, and then the pre and post, the pre-op angles. And based on my experience, and this is where AI would help if I have more data, but I'll put in the lens either horizontally or vertically. And I actually tend to aim for vertical if it's toric. If it's spherical, I just kind of aim for the one that will give us the maximal angle, but a volt of greater than probably 400. I just did a small study, and we looked at 18 toric lenses, and 13 I put in horizontally, 5 vertically. And we're not as advanced, and we just measured, now we're changing it so that we're measuring the volt with an OCT. But in the past, what we did was just look at it with a slit lamp, and we based it on the central corneal thickness, and that's based at 550. But what we found is for the toric, the angle reduction was 11 degrees, and for the spherical, because I'm kind of aiming for larger post-operative angles, the reduction was 9 degrees because I sized it smaller. We did a retrospective review of 31 eyes implanted in the last 3 years in our centers, 4 surgeons, and we had a total of 14 exchanges. So again, we're looking for the probably between, I can't tell exactly what the volts were, but again, the focus is not the volt, but I would say the volts are from 400 to 1,000 microns. And we had 14 total exchanges. 12 exchanges were for rotation of the toric lens, and 2 were for, in one patient, it was just a complete outlier. It was this, even I rotated, the lens vertically, it was just an outlier. So it was the same patient, and we had this one patient that we had to exchange out the lens. So using my technique of looking at the CBID, the lens rise, I look at all these things, look at what the formula is predicting, I look at the pre-op angle, I utilize vertical and horizontal placement, I perform one eye at a time if necessary, doing the surgery on the second day. Sometimes in between the eyes, I don't have the intraoperative machine that Dr. Dan Reinstein's going to talk about, but I do take out the patient and look at the slit lamp and look at the volts. I'll measure the angle with the OCT and see where it is. It's not completely accurate. I'm going to do a study to see how accurate that is to correlate with later. But using this method, actually in the last 1,000 eyes, I've had 0 exchanges. So, I mean, people always say, well, exchanges are easy and all that, but honestly, I don't want to put in a lens and take it out when there's a risk of cataracts in a young patient. So we did review the literature, and what we noticed is that even Dr. Lee, using his method and his experience, his exchange rate was about 3% or so. So the most accurate is to really use the Insight 100, in my opinion. Most of the implanters are still going to use white to white, as we've seen. Even in Korea, it's done hundreds of thousands of lenses viewing, and most people are going to do that and use a white to white. So you really have to have the right fudge factor, and you really need to understand and put that into the really the Stella formula. And we're doing a study right now to see how we can use our data from ArcScan to find the right fudge factor for people that are still going to continue using white to white, because that's what's probably most people are going to do, and get better results. So I'm really dedicated to people getting the best results, and if they're not going to use the Insight 100, then they should use really the OCT, which should be readily available and with these formulas. If they're going to use white to white, then they should have the right fudge factor and understand, because it's really important to have great results, because otherwise we're going to have a bad reputation as this procedure goes on and we have more complications that pop up. So in summary, this is my method, and it's been a real game changer for us. And we're looking at more things. I want to give my data set to Dan so that we can put these racial variations and understand. We really want to understand about pre and post-operative angle, which I think is the focus and not the vault. And we want to use AI and all these tools to further customize and optimize lens selection. Thank you so much.
Excellent.